Welcome to Pulse Pressors, where critical care gets crystal clear. PVR is the pulmonary analog of systemic vascular resistance, calculated as 80 times mean pulmonary artery pressure minus wedge pressure, divided by cardiac output. While SVR reflects LV afterload, PVR reflects RV afterload. Because the RV is thin-walled and low pressure, it cannot handle even modest increases in resistance. PVR rises long before mean pulmonary artery pressure, mPAP, becomes noticeably abnormal, making PVR the earliest marker of evolving RV dysfunction. Normal PVR ranges from 20 to 130 dynes per second per square centimeter to the power of -5. Once PVR exceeds 240, pulmonary hypertension is present. At values above 400, the RV begins to struggle. At PVR above 600, RV failure becomes almost inevitable unless corrected. Indexed PVR, PVRI, further normalizes resistance for body size. PVR is therefore not just a number, it is an escalating threat to RV function. Just like SVR, PVR is governed by vessel radius, tone, and compliance. Because resistance is proportional to 1 over radius to the power of 4, even slight vasoconstriction in the pulmonary arteries causes dramatic increases in PVR. Pulmonary vascular compliance, a measure of how stiff the pulmonary arteries are, plays a major role in RV afterload. Lung volume influences PVR. Both hyperinflation and atelectasis increase resistance. The RV is exquisitely sensitive to changes in afterload, making PVR a critical metric. RV afterload is not just resistance, it is also the pulsatile stiffness of the pulmonary arteries, PAC. PVR reflects steady resistance, but PAC reflects the compliance of the pulmonary vasculature. A patient may have a normal PVR, but extremely low PAC, resulting in severe RV stress. Conversely, a high mean pulmonary artery pressure mPAP does not necessarily mean high PVR. RV afterload requires assessing both PVR and PAC. PVR elevation develops silently. First, CVP rises and PA pulsatility falls. Next, RV stroke volume declines and the septum shifts, impairing LV filling. Eventually, low cardiac output results in renal venous congestion and systemic shock. Importantly, PVR often rises before the clinician sees overt hemodynamic deterioration. RV failure is frequently a late recognition event unless PVR is tracked. Factors that increase PVR include hypoxia, hypercarbia, acidosis, high lung volumes, atelectasis, pulmonary embolism, ARDS, and pulmonary hypertension. Mechanical ventilation, especially with high PEEP or high driving pressure, increases alveolar distension and raises PVR. Correcting oxygenation, ventilation, and lung mechanics is therefore as important as pharmacology. Low PVR can also be misleading. Septic shock reduces PVR through vasodilation, even if the RV is struggling. Cirrhosis produces a chronic high-flow, low PVR state. Pulmonary vasodilators artificially lower PVR. In end-stage RV failure, forward flow collapses so severely that calculated PVR appears low. This pseudo-normal value does not reflect the underlying pathology. Like SVR, PVR is a derived number with pitfalls. Overestimating wedge pressure reduces the numerator and yields falsely low PVR. Underestimating cardiac output yields falsely high PVR. Mean pulmonary artery pressure must be measured at end expiration for accuracy. Severe tricuspid regurgitation distorts thermodilution-based cardiac output measurements. PVR is most accurate when interpreted with PA waveforms, respiratory phase awareness, and the clinical picture. Clinical cases highlight PVR's power. In acute PE, PVR often exceeds 700, signaling impending RV failure and the need for thrombolysis or catheter-directed therapy. In ARDS, high driving pressures elevate PVR even when lung function appears acceptable. In septic shock with high cardiac output, PVR may appear normal, while the RV is struggling with low compliance. In pulmonary hypertension, PVR often exceeds 800, requiring RV protective strategies. PAC, pulmonary arterial compliance, is arguably as important as PVR. PVR reflects steady resistance, but PAC reflects how stiff the pulmonary arteries are and how much pulse pressure the RV must generate. Low PAC is an early marker of RV failure. Because PAC declines as PVR rises, both must be interpreted together. Treating RV failure requires reducing PVR and supporting RV contractility without causing additional stress. Avoid hypoxia, acidosis, and hypercarbia. Avoid overdistension with high PEEP or high plateau pressures. Address pulmonary vascular obstruction with anticoagulation or thrombolysis. Use pulmonary vasodilators such as nitric oxide or prostacyclin. Maintain adequate RV perfusion pressure with MAP above 65 to 70. Use inotropes if RV contractility is impaired. Avoid unnecessary fluids if CVP is rising and PVR is elevated. Mechanical circulatory support creates additional complexity. VA ECMO reduces PVR and unloads the RV, but may increase LV afterload. Impella RP provides direct RV support. Rising CVP with falling LV preload on ECMO suggests evolving RV failure. Monitoring PVR trends remains essential even with full support. PVR is a key classifier in shock. Distributive shock usually shows low or normal PVR. LV cardiogenic shock generally has normal PVR, unless lung mechanics worsen. RV shock features elevated PVR, high CVP, and low cardiac output. Mixed shock patterns depend on underlying pathologies. PVR distinguishes RV failure from LV failure, something no systemic metric can do. The expert takeaway: PVR is the RV's afterload, and even small increases can precipitate dramatic deterioration. PVR must be interpreted alongside PAC, CO, PEEP, pH, and lung mechanics. RV shock is a silent killer because early changes in PVR are subtle unless specifically monitored. Protecting the RV is one of the most important actions in preventing hemodynamic collapse. So, this is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.